Great, thank you so much. So the webinar today is STI Updates, What You Need to Know, being presented by Dr. Jason Zucker. Dr. Zucker is an assistant professor in the divisions of adult and pediatric infectious diseases at Columbia University Medical Center and the assistant medical director at the New York City STD HIV Prevention Training Center. Dr. Zucker, if you'll just go to the next slide, I'll just talk us through the housekeeping briefly. Thank you. So everyone will be on mute during the webinar. There is the Q&A tab that you should see at the bottom of your Zoom screen. Please send your questions in that tab and we'll plan to answer those likely at the end of the webinar. And then as far as CE instructions go, you will receive an email later today with instructions on how to claim CME or CNE. You will have until July 28th to do so. And once the webinar recording is available on our website, I'll share that as well. So at this point, I'll turn it over to Dr. Zucker to take it away.
Great. Thank you so much all for joining today to talk about STI updates. I have no financial disclosures. The goals for today are really to talk about some of the important updates in the 2021 STI treatment guidelines, to talk about the rationale for these updates or why we're changing some of our practices, and try to illustrate how to apply these guidelines to your practice. As Jessica mentioned, please use the Q&A tab, and I will try to address questions as we go along if I can. So the first thing is just an opening to remind us that sexually transmitted infections are important. Since 2017, there's been a reported 4.7% decrease in chlamydia, although a lot of people think that it has to do with decreased testing. There's been a 25% increase to almost 700,000 cases per year of gonorrhea, an increase of almost 70% to 171,000 cases of syphilis, and a staggering 185% increase in cases of congenital syphilis to almost 2,700 cases in 2021. And I can tell you that when the 2022 numbers come out, they'll be even higher. These trends are not just national, they're local for you in Michigan as well. On the right-hand side of this screen, you can see that I've grabbed the Michigan numbers, and you're seeing the same trend with increasing cases of syphilis, increasing cases of gonorrhea, and a semi-flat but relatively high cases of chlamydia. And so these are really important things for us to think about and be able to test and treat. In addition to being prevalent, STIs are also costly, with $1.1 billion in direct medical costs attributed to just chlamydia, gonorrhea, and syphilis, the three most common and easily treatable sexually transmitted infections. So what we're going to cover today is primarily out of the 2021 STI guidelines. These were the first guideline updates since 2015, so in 6 years. That's a really long time in medicine and really changed a lot of our practice. Just to prepare you, the guidelines are 192 pages and include over 1,450 references. To set expectations, since we only have an hour, I'm going to try to talk about the most common things that you're likely to see in your practice with a focus on changes from prior iterations of the guidelines. If there's anything you feel like you need more information about, please feel free to reach out after the end of the talk. And again, please feel free to interrupt me as we go. So I have a few patients we're going to use for today. I always like to try to put this in the context of real patients. These are based on real patients that we saw in our sexual health clinic. In the interest of time, I'm not going to provide you all the details about them, but just use them to provide some context for today's discussion. So these are two common cases I see in sexual health clinic. Jack is a 29-year-old bisexual male. He comes in complaining of dysuria and penile discharge. Jill is a 24-year-old bisexual female, coming in complaining of dysuria and vaginal discharge. So just as a reminder, the first thing we should always plan to do is to take a detailed and comprehensive sexual history. Sexual health can greatly impact the overall quality of life, and the health impacts of STIs can range from irritating to life-threatening. Discussing patients' sexual health offers us the opportunity for counseling and sharing information about behaviors that may increase or decrease STI risk. The CDC recommends that a sexual history be taken as part of routine healthcare, in addition to when there are symptoms or physical exam findings concerning for an STI. A sexual history really allows you to provide high-quality care by appropriately assessing and screening individuals for a broad range of sexual health concerns. And I know that Dr. Kohal was here recently and went through how to take a sexual history, so we're not going to cover that today. But this is just a reminder that taking a sexual history is important because it affects our recommendations. So these are the current gonorrhea and chlamydia screening recommendations. Oh, sorry, that should say gonorrhea and chlamydia screening recommendations. And if you look, I've underlined the fact that for a lot of patients, the frequency or need for screening is based on their individual risk. So for men who have sex with men, they should be tested at least annually, but every 3 to 6 months if it increased risk. For persons living with HIV, they should be tested at least annually, but also more frequently depending on individual risk behaviors. Non-pregnant women based on sexual behaviors and exposure. For pregnant women, more frequent screening during pregnancy if it increased risk. What I'm trying to highlight here is the importance of taking a sexual history because it really does impact what you're going to offer and how often you're going to offer that to patients. So going back to our first patient, Jack. So we did our standard STI workup for Jack. So this is what we do for most patients who come into our STI clinic complaining of dysuria. So we did an HIV test with a 4th generation HIV antibody antigen test. Hepatitis C testing as it's recommended annually for men who have sex with men. Gonorrhea and chlamydia testing with 3-site gonorrhea chlamydia NAT or extragenital gonorrhea chlamydia testing. We try to do a gram stain if we're able, syphilis testing with an RPR, and an offer of HIV biomedical prevention services like PEP and PrEP. So the first thing I want to highlight today is that the emphasis on extragenital testing. In previous iterations of the guidelines, it was recommended to do extragenital testing only for men who have sex with men based on reported behaviors. However, the guidelines have been updated to really expand on that. They now recommend offering extragenital testing to men who have sex with men who do not report exposures at these sites. This is due to an unknown underreporting of risk behaviors. So for example, if we ask people just about insertive or receptive anal sex, that does not mean that means we may miss people who use toys, who use fingers, who engage in oral anal sex. And so honestly, what we really should be doing is offering extragenital testing to all men who have sex with men. And it's not just men who have sex with men. They also now recommend considering rectal chlamydia, gonorrhea, and pharyngeal gonorrhea testing for females through shared decision-making based on their sexual history. What they're really getting at is that we're encouraging the expansion of extragenital testing. And as we go through, I'll show you exactly why. The reason we're focused on extragenital testing is the desire to reduce misdiagnoses and because it may affect our management. So as you'll see as we go through today, identifying the site of positivity can impact both appropriate treatment as well as when patients need to come in for follow-up. So let's start with looking at misdiagnosis. So this is one of many studies that show the same thing, but it's one of my favorites. It was a study done at the Kansas City Health Department STD clinics, looking at over 9,600 clinical encounters. And what they found was that most cases, more than half of cases of gonorrhea and chlamydia in men who have sex with men would have been missed had extragenital testing not been performed. But not just that, 1/3 of cases of extragenital gonorrhea and chlamydia in men who have sex with women and women who have sex with men would have been missed had only urogenital testing been performed. So it's so impressive. I actually want to show it to you visually because I think it really hammers the point home. So this is the table from that paper, and I've tried to label it and we'll walk you through it. The left-hand side is gonorrhea. The right-hand side is chlamydia. The top boxes are pharyngeal infection, and the bottom boxes are rectal infection. The darker black, dark gray color, is extragenital testing only, while the lighter gray color is extragenital plus genitourinary infection. So this darker gray color are the infections that would have been missed had the patient only gotten genitourinary testing. And so as you can see in men who have sex with men, that darker gray color really predominates, meaning that without doing extragenital testing, more infections would be missed than would be picked up. But we often sort of intuitively know that's true for men who have sex with men. But even women who have sex with men and men who have sex with women, a substantial portion of cases would be missed if extragenital testing was not performed. In terms of extragenital sample collection, I know that you guys have a great screening site orientation manual that I reviewed before this talk. It really walks through nicely how to collect samples. As a reminder, for the pharyngeal swab, you just swab both tonsillar pillars and the posterior pharynx. And for the rectal swab, insert the swab into the rectum and rotate gently around the rectum for 5 to 10 seconds. And as a reminder, we should be testing each site of exposure at least annually or every 3 to 6 months if at risk, regardless of condom use. They have really great pictures in that same guide about exactly how to walk you through collecting using the Hologic system. And so I'm not going to spend time on that today, but I will take any questions at the end. So going back to Jack. So Jack's testing was done. We actually did a gram stain from his urethral discharge that I recognize that not every site can do. And we found that he had gram-negative intracellular diplococci. That's consistent with a diagnosis of gonorrhea. In terms of our new treatment recommendations, we do have new guidelines for the treatment of gonorrhea. This is specifically for patients where the diagnosis is made and you suspect that they only have gonorrhea. So in this case, the ceftriaxone dosage has increased from 250 to 500 milligrams, and it's now weight-based to be 1 gram if patients are greater than 150 kilograms. For those of us who've been doing it for a while, it feels like a big change, but they no longer require dual therapy with azithromycin. So if you have a patient who maybe was asymptomatic that you did testing on and you found positive gonorrhea, you can treat them solely with ceftriaxone. You do not need dual therapy with azithromycin. However, in many cases, you will not necessarily know what the patient has when they're coming in symptomatic. And so the recommendation is that if chlamydia has not been excluded, meaning you don't know that they don't have chlamydia, we should treat empirically for gonorrhea and chlamydia. And now for chlamydia, the recommendation is doxycycline, 100 milligrams by mouth twice daily for 7 days, with azithromycin being an alternative regimen, including for those patients that are pregnant. So starting with gonorrhea first, just as a reminder, the dose is now ceftriaxone 500 milligrams. We do have alternative agents for patients who have true allergies to cephalosporins. The first agent is gentamicin 240 milligrams intramuscularly, plus azithromycin 2 grams by mouth. The second is cefixime 800 milligrams by mouth as a single dose. For those who remember cefixime from previous iterations of the guidelines, this is a higher dose, and cefixime resistance has come down since we are using it less. However, while this is a possible regimen, we know that cefixime does not provide as high or as sustained bactericidal blood levels as ceftriaxone. It also demonstrates extremely limited treatment efficacy for pharyngeal gonorrhea, so we have to be careful about using it. Finally, there's considerable quinolone resistance amongst gonorrhea isolates. However, the CDC is really preparing us for a future with resistance-guided therapy. In the future, your GCCT tests are likely to come back with some markers of resistance. One of those is GRA testing, and if GRA is negative, you can consider using ciprofloxacin. However, that's more for the future than currently. As a reminder, none of these alternative regimens are reliable alternatives for pharyngeal gonorrhea, again highlighting the importance of extragenital testing to know where your positive site is. So this is a big change. So why did we make this change for gonorrhea? Well, there's 2 reasons I want you to think about. The first is antimicrobial stewardship, and the second is pharmacokinetics and thermodynamics. The first reason under antimicrobial stewardship is increasing gonorrhea resistance to azithromycin. This blue box here is azithromycin resistance. And as you can see, since 2013, it's increased more than 7-fold. So the first reason to remove azithromycin from the guidelines is that it's less likely to provide an added benefit in treating gonorrhea. And we're developing more and more resistance to it, so we won't have it if we need it. The second reason is increasing azithromycin resistance in other pathogens, particularly GI pathogens that may be more common in people with higher rates of STIs, things like Salmonella, Shigella, and Campylobacter. These are all antibiotic-resistant threats across the United States. The third reason is selection for non-macrolide resistance. This was the example they included in the guidelines, and it was a study of mass distribution of azithromycin to preschool children in sub-Saharan Africa. They found that mass distribution of azithromycin reduced childhood mortality, but at the cost of amplifying macrolide resistance. That wasn't particularly surprising, but what was surprising is that it wasn't just azithromycin resistance. Continued azithromycin distribution selected for non-macrolide resistance, including resistance to beta-lactam antibiotics like cephalosporins. So antimicrobial stewardship is really why they removed azithromycin from the gonorrhea guidelines. But why did they increase the dose of ceftriaxone? Well, that's our second category, pharmacokinetics and thermodynamics. One thing we know is that we're seeing a rise in the minimal inhibitory concentration, or MIC, of ceftriaxone for gonorrhea worldwide. That means that we actually need more medication to be able to treat it, because ceftriaxone levels need to be greater than the MIC for about 24 hours for adequate treatment. There is a national surveillance network that monitors gonorrhea MICs. And while we haven't seen a lot of MIC creep in this country, it's been seen in others. In Australia, they increased to 500 milligrams of ceftriaxone almost 4 years ago. And in England, where they've seen several cases of highly resistant gonorrhea, they've actually increased to 1 gram without azithromycin. And while it seems like a worldwide problem, everything that happens worldwide eventually makes it here. And so, for example, in Massachusetts recently, a novel strain of multi-drug non-susceptible gonorrhea with reduced susceptibility to ceftriaxone, cefixime, and azithromycin, and resistance to ciprofloxacin, penicillin, and tetracycline was identified. We expect to see more of these cases over time, and so the higher dose of ceftriaxone may help when there's a reduced susceptibility to ceftriaxone. The second reason is pharyngeal disease, and there are 2 reasons we really worry about the pharynx. The pharynx tends to be screened less often than other sites, and globally, most ceftriaxone-based treatment failures have involved pharyngeal gonorrhea. Ceftriaxone concentrations also tend to be more variable in the pharynx. And again, treating gonorrhea requires concentrations greater than 24 hours above the MIC. And so variable concentrations will be a problem with treatment. And the hope is that by increasing the dose, we can overcome this challenge. Once you make the diagnosis and treat gonorrhea, the next step is to understand follow-up. So unchanged from before is to abstain from sex until 7 days after completing treatment. We should be thinking about assessing for treatment failure if patients have persistent symptoms at 3 to 5 days. So if your patient is still symptomatic at 3 to 5 days, you should think about bringing them back in for a culture with antimicrobial susceptibility testing, as well as repeat NAT. A new recommendation is that they recommend a test of cure for all pharyngeal infections at 7 to 14 days. And so I frequently get asked, do I really need to do extragenital testing if I'm just going to treat someone empirically? And one of the many reasons I say yes is that it now changes your follow-up management with a test of cure at 7 to 14 days for pharyngeal. For people who are pregnant, they should get a test of cure at 4 weeks. And for everyone else, they should get rescreened at 3 months for reinfection, as reinfection is the most common reason for people continually testing positive. So whenever I highlight this 7 to 14 days, I always get a question about whether you're going to pick up just dead organisms on the test. And we know that persistent non-viable organisms can cause false positive results. However, reinfection from re-exposures are a much more common cause for persistent positive tests. If you look here, this is data on the RNA NAT, which is what most of us use. And you can see that at 0 to 7 days after treatment, persistent positivity is about 8.7%. At 8 to 14 days, it's 2.2%. And at 15 days and greater, it's 1%. And so I personally always recommend retesting closer to the 14-day window. But again, you would not expect too many false positives, even at 8 to 14 days. So based on the gram stain, Jack was empirically treated with ceftriaxone of 500 milligrams times 1. And that begs the question we always get at this point, is should Jack have received treatment for both gonorrhea and chlamydia if gonorrhea is known, but chlamydia testing is pending? And the CDC says that this is really clinical judgment. They recommend including a regimen for chlamydia infection if chlamydia infection has not been excluded. However, we're all clinicians and we can consider the setting and how easy it will be to reach and treat patients when results return. For example, Jack had been a patient of mine for 5 years. Every time I text him, he comes in for testing or treatment as needed. And so I can trust that he's reliable and will come back in. For new patients or patients who are coming in for first-time screening, you likely want to offer them both ceftriaxone and doxycycline because they may be harder to reach, or you don't know how easy it will be to get them back in for treatment. So Jack's results came back positive for urine gonorrhea and remaining testing negative. And we'll come back to Jack again shortly. So Jill got a very similar workup to Jack. She got hepatitis C testing as well because she'd never had it before. And the USPTF does recommend lifetime screening for everyone now. We also added in trichomonas because trichomonas should be performed for women seeking care for vaginal discharge. As a reminder for men, it's only recommended for men with persistent symptoms. We did a gram stain for her as well that didn't see any evidence of organisms. And given her negative gram stain, we were really thinking about non-gonococcal causes of urethritis. Now, a lot of practices don't do gram staining, but I want to highlight this case because the lack of gonorrhea on gram stain means that we need to think about non-gonococcal causes of cervicitis or dysuria. We have our most common pathogen, which is chlamydia, but we also have some new pathogens that are highlighted in the updated guidelines. We've added Mycoplasma genitalium to this list, and it's more prevalent than even trichomonas that we'll talk about coming up. Neisseria meningitidis has been added to the list. And most importantly, an acknowledgement that about half of these cases of non-gonococcal urethritis may end up unknown and may be non-infectious, particularly in cases of cervicitis. So let's start by thinking about if we want to treat chlamydia, since it's the most frequently reported bacterial infection disease in the US. Previously, we used azithromycin or doxycycline for the treatment of chlamydia. However, now doxycycline 100 milligrams twice daily for 7 days is the preferred regimen. It's important to know that azithromycin has not been removed from the guidelines, but it's been moved to an alternative regimen along with levofloxacin for 7 days. It's important to remember that because of this change, that doxycycline is to be avoided in pregnancy, and azithromycin remains preferred in pregnancy with amoxicillin as an alternative option. Erythromycin, for those who remember it, has been removed from the guidelines due to the frequency of GI side effects. So why did we make this change? Obviously, going from a single 1 gram once to twice daily for 7 days is a huge change. So why did we make this change? Well, if you remember for gonorrhea, we talked a lot about PK, PD, and resistance, but we don't see a lot of resistance in chlamydia. In gonorrhea, we talked about the pharynx, and here we'll talk about the GU tract, and most importantly, rectal infections. So let's start with genitourinary infection. There was a randomized controlled trial that compared oral azithromycin with oral doxy for the treatment of urogenital chlamydia. The primary endpoint was treatment failure at 28 days. And in the context of a closed population, the efficacy of azithromycin was 97% versus the efficacy of doxy being 100%. And the non-inferiority of azithromycin was not established, or stated differently, doxy might be better than azithro for the treatment of urogenital chlamydia infection. But to be quite honest, given the 97% effectiveness of azithromycin and its ease, I suspect this alone would not have been nearly enough to change the guidelines. But what about rectal infection? We now have 2 randomized placebo-controlled trials, one in Seattle and Boston, and one in Australia, that combined enrolled 384 patients and demonstrated that a 7-day course of doxycycline was significantly more effective than a single dose of azithromycin, with a 20 to 26% difference in efficacy. Said differently, if you use azithromycin for people with rectal chlamydia, up to 1 in 4 or 1 in 5 may fail due to that difference in efficacy. And so doxycycline is clearly better for rectal infection. But does that matter for everyone? Now, I said earlier that the updated guidelines suggest that rectal screening can be considered for females on the basis of reported sexual behaviors and exposure. But receptive anal intercourse is a poor indicator of the need for rectal treatment because it's not just sexual behaviors that matter. Rectal infection is not uncommon among women with genitourinary infection, with rates ranging 33 to 83%, regardless of behavioral risk factors, likely due to auto-inoculation from the urogenital site. If rectal chlamydia is inadequately treated, women are at increased risk for repeat urogenital chlamydia infection through auto-inoculation from the anal rectal site. And women are the ones who suffer the most from chlamydia, with complications such as PID and infertility. So treating rectal chlamydia adequately is important. And so an important reason for this change is that doxycycline is superior to azithromycin, as we just discussed. And there is also a randomized controlled trial that you'll see here for women that demonstrated the superiority of doxycycline as well. So in choosing a treatment for chlamydia, you're really trying to balance the efficacy of doxycycline versus the ease of azithromycin. Access is one big difference. Many clinics and emergency departments may be unable to provide a 7-day course of doxycycline, while many can provide a single dose of azithromycin. Patients who are uninsured may only be able to obtain what they can get from the clinic or the ED. This challenge is magnified for adolescents and young adults. For example, in one study from Washington, D.C., they found that only 58% of adolescents with an STI diagnosis filled their prescription. And so there is a benefit to being able to treat people on site. Adherence is a second difference. It's obviously easier to take 1 gram once than it is to take a medication for 7 days. However, one thing that's important is to set our judgments aside. When the gonorrhea update came out, there was a lot of concern about 7 days versus 1 dose, but I find that most patients can do it, and frequently the ones that can't tell you. Additionally, in the recent randomized controlled trials, azithromycin performed so poorly that even in the context of imperfect adherence, doxycycline is likely better. Confidentiality, patients may value not having pills in the house, and they may not want a parent or friend or roommate to find out, and being able to treat them at the point of care may be beneficial. Finally, side effect profile. For example, people taking doxycycline are supposed to avoid significant sun exposure. So what happens if you're supposed to leave for a beach vacation? So these are all things to think about when deciding between these two. And this in general, this is our recommended approach. If there's suspected or possible chlamydia, rectal chlamydia, it really should be doxycycline. If there's a possibility of pregnancy, it should be azithromycin. And if neither of those is true, it's really a shared decision-making approach with doxycycline as the preferred agent. In terms of follow-up for chlamydia, again, people should abstain from sex until partners have completed treatment or 7 days after single-dose therapy. We should consider repeat testing at 4 weeks for rectal chlamydia if you're treated with azithromycin due to the lower efficacy. Again, test of cure at 4 weeks if pregnant, and also always rescreen at 3 months for reinfection. And so Jill received doxycycline 100 milligrams twice daily for 7 days. We did talk to her about HIV prevention services like PEP, and she declined expedited partner therapy. The following day, her labs returned positive for urinary and rectal chlamydia. And so it's good she's taking doxycycline, but she was also urinary trichomonas positive. So what else do we have to do? So I want to highlight this change in the trichomonas treatment for women. The main difference in the recommended treatment of trichomonas for women is that the treatment is now metronidazole, 500 milligrams twice a day for 7 days, as opposed to previously single-dose therapy. And this was based largely on this randomized controlled trial that compared single-dose versus 7-day treatment in women. The primary outcome was test of cure at 4 weeks after treatment. And what you can see is that the 7-day group was about half as likely to still be positive at 1 month than those who received the 2-gram single dose. And that really led to the change to go from 2 grams single dose to 500 milligrams twice daily for 7 days. So the recommended regimen for treatment trick for women is now metronidazole 500 milligrams twice daily for 7 days. There is no published randomized controlled data on treatment for men, and so men can still be treated with a single 2-gram dose of metronidazole. And tinidazole remains an alternative therapy for both men and women. One other thing I think it's important to highlight, and this is one my patients seem to be most excited about, the 2015 guidelines said that alcohol consumption should be avoided during treatment with things like metronidazole. After further review, the 2021 guidelines state that abstaining from alcohol after metronidazole is not needed. Prior studies were based on animal studies and case histories, and the adverse effects may be related to the drug or alcohol independently. Metronidazole does not inhibit acetaldehyde dehydrogenase like disulfiram, and so there's no reason to counsel patients about abstaining from any alcohol use after using metronidazole. And so while Jill was initially given doxycycline, when her results returned, we prescribed a 1-week course of metronidazole. Jack comes back. So Jack actually came back about a week later. He'd said he had no sexual contact since his last visit, but his dysuria really hadn't gotten a lot better. He had received ceftriaxone for genital urinary gonorrhea, and chlamydia testing was negative. We did a repeat gram stain, which was negative. And so we started to think more about non-gonococcal urethritis. So going back to non-gonococcal urethritis pathogens, chlamydia is generally the most likely, but his previous testing at 3 sites was negative. Mycoplasma genitalium is something that should be considered in persistent urethritis, and so it's something to think about here. Trichomonas is more common in men who have sex with women, so it's also something to think about here as Jack is bisexual. So we ended up testing him for both MGen and trichomonas, and he came back positive for Mycoplasma genitalium. So I love Mycoplasma genitalium. In the last set of guidelines, it was categorized as an emerging pathogen, but now it's emerged in here. Since it's likely a new pathogen to many people, this slide is my everything you need to know about MGen slide. MGen is something we should be thinking about in patients with persistent or recurrent non-gonococcal urethritis. That means it's not something we're going to send right away. but send on patients who don't respond to initial therapy. We can think about testing in PID, and we do not recommend asymptomatic screening for anyone. The recommendations, the way to test is with an FDA-approved genital or urinary NAT, the same way we test for gonorrhea or chlamydia from the genital urinary site. We're actually seeing significant amounts of resistance, ranging from 44 to 90% for macrolides like azithromycin, and even quinolone resistance as high as 15%. You'll see in a few slides from now, treatment is resistance-guided therapy, and sex partners of symptomatic persons are tested or treated only if positive. So we don't even routinely treat all exposed partners. One of the reasons for that is that MGen is surprisingly common. In one study that looked at men with urethritis symptoms, they found that more than 1 in 4 men with urethritis were co-infected with Mycoplasma genitalium. In terms of treatment, this is another example of the guidelines using resistance-guided treatment. Currently, commercially, macrolide sensitivity is not necessarily available. If it is available, you can use azithromycin if sensitive. So it's 7 days of doxycycline, followed by 4 days of azithromycin. Otherwise, for most sites that don't have resistance testing available, the treatment is doxycycline 100 milligrams twice daily for 7 days to reduce the bacterial load, followed by moxifloxacin 400 milligrams twice daily for 7 days. So our patient Jack completed a 7-day course of doxycycline, followed by a 7-day course of moxifloxacin with resolution of his symptoms. So everything with Jack got better. However, he came back a few months later. In March, during the early part of the COVID outbreak, he went to urgent care with rectal pain. STI testing was sent, but he's not sure exactly what was sent, and he never received his results. He was treated on-site with ceftriaxone and azithromycin, and 1 week later, he developed a rash that was attributed to the antibiotics he received. But it wasn't a rash, it was syphilis. So to understand syphilis, we really need to understand the proper staging of syphilis. This diagram is from the New York City STD Prevention Training Center and New York City DOH monograph. And Jessica will put the link to this in the chat, but it highlights the stages of syphilis really well. So it starts with the incubation period. The incubation period after a recent exposure can be between 9 and 90 days. This means that testing near to an exposure can be falsely negative, and patients may require treatment. And so this is why I always tell people if someone was exposed to somebody with syphilis, you really have to think about treating them presumptively or empirically, because testing can be negative for up to 90 days, even if they're infected. We're going to move to latent syphilis. Latent syphilis, by definition, are patients with no clinical manifestations. Usually, this infection can only be detected through serologic screening. Early latent syphilis means that we know for a fact the duration of infection is less than 1 year. Latent is duration of infection greater than 1 year. And latent syphilis of unknown duration, as you can imagine, we're unsure due to a lack of testing availability how long the patient's been infected with syphilis for. As a reminder, latent syphilis requires no exam findings of primary, secondary, or tertiary syphilis. For latent syphilis, to really understand it, you need to understand titers or be able to interpret titers. These are syphilis titers, and these are serial dilution. So non-reactive are patients that are negative. 1 to 1, 1 to 2, 1 to 4 are serial dilution. What you often see is a 1 dilution change or a 2-fold increase or decrease in titers, which is within the standard error of the test. And so we don't consider a 1 dilution change or a 2-fold increase or decrease in titers to be clinically significant. So again, people who test positive for syphilis will often test positive for syphilis for a long time. What you're really looking for to look for evidence of new infection or evidence of adequately treated infection is a 2 dilution change or a 4-fold increase or decrease in titers. So for example, going from 1 to 8 to 1 to 32 would represent a new infection. And over the course of a year, going from 1 to 32 to 1 to 8 would represent an adequately or appropriately treated infection. Following exposure, we're going to go back now after finishing latent syphilis. We're going to talk about primary syphilis. So following exposure, local primary syphilis occurs at the site of inoculation, which often results in the development of 1 or more primary syphilis skin lesions. This is an example of one on the tongue. As a reminder, they're local. You can have one or more ulcers or chancres at the inoculation site. Because they're traditionally painless, they can go unnoticed. So that's something I always remind people, just because someone didn't see the chancre doesn't mean that they didn't have one. It could have been in the throat, it could have been in the rectum, it could have been in the vagina. Because it's painless, if it's not a site that you can see easily, it can go unnoticed. It can be associated with regional or bilateral lymphadenopathy, which can also often be disturbing to patients or providers who are not thinking about syphilis and might think about worse diagnosis that's associated with lymphadenopathy. It generally occurs 10 to 90 days after infection, is highly infectious, and resolves in 1 to 6 weeks. One thing I want to highlight today is that we are seeing more and more atypical presentations of syphilis, and this has been included in the updated guidelines. So for many of us, the single painless chancre of primary syphilis was drilled into our head. However, we're seeing more and more atypical presentations, including multiple, atypical, and painful lesions, including and most prominently in the rectum. So as always, syphilis can look like almost anything. It needs to be on our differential diagnosis for rectal pain or any other lesion, and a high index of suspicion is needed to not miss the diagnosis. In contrast to the localized findings of primary syphilis, secondary syphilis is disseminated, systemic form of infection. It most frequently occurs 4 to 8 weeks after the primary ulcer. However, in some patients with evidence of secondary syphilis, the primary chancre might still be present. As a reminder, secondary syphilis is disseminated. The systemic symptoms most common that we think about are dermatologic manifestations, like the rash on the hands and feet. However, you can also get painless generalized adenopathy, low-grade fevers, fatigue, flu-like symptoms, and it usually resolves 4 to 8 weeks after infection. Usually resolves in 6 weeks and is highly infectious. And these are just some examples of the rash of syphilis. But again, it can look like almost anything. Another thing that's important to keep in mind is that secondary syphilis is disseminated. And so it can present with findings not just rash, but lymphadenopathy, hepatitis, usually seen on labs, nephrotic syndrome, arthritis, neurologic symptoms, ocular otic symptoms. Secondary syphilis can present with a lot of different symptoms. And so it's important to, again, think about that when you have patients who might be at risk for syphilis presenting with systemic symptoms. Going back to our patient, Jack, who initially came in with rectal pain and then developed the rash. About 2 months later, he was having a hard time hearing the TB. He went to the ED where he was seen by ENT. They diagnosed him with asymmetric hearing loss and recommended an MRI. The MRI was normal and he was told to follow up outpatient. A month after that, he felt like he was having a hard time seeing the TB. He went to the ED where he was seen by ophthalmology and was diagnosed with panuveitis. They recommended sending a panuveitis workup, which for me and ID generally comprises an RPR and a quantiferon gold, and was told to follow up outpatient. So obviously, given today's topic, we're going to be talking that he has syphilis. And one thing I really want to highlight is that the ocular and otic involvement can actually occur at any stage, even though we've traditionally thought of them as late stage manifestations. Early neurosyphilis usually occurs a few months to a few years after initial infection. Ocular and otic involvement can occur with or without other neurologic signs or symptoms. Ocular neurosyphilis most often presents as posterior uveitis or panuveitis with other vision symptoms. And so we really need to have a high suspicion of syphilis in these cases as well. As I said, there's enhanced descriptions of ocular and otic manifestations in the updated guidelines. Ocular syphilis most commonly presents as panuveitis, but can actually involve any structure of the eye, including conjunctivitis, anterior uveitis, posterior interstitial keratitis, optic neuropathy, and retinal vasculitis, and can lead to permanent vision loss. Otosyphilis typically presents with cochleovestibular symptoms, including tinnitus, vertigo, and sensorineural hearing loss that can be unilateral or bilateral, be sudden in onset, and progress rapidly. It can also result in permanent hearing loss. I hope you notice that both of these things truly are emergencies because the vision and hearing loss can be permanent. To assist with screening for these things, we do have a screening tool for neurosyphilis that was developed by Kings County at Washington State. And it's a really short 13-question symptom questionnaire that takes just a few seconds to do and is really worth reviewing with your patients, particularly if you're diagnosing them with syphilis. In terms of syphilis testing, I don't think there are good recommendations to screen, given just how quickly syphilis is increasing year over year, with an almost 70% increase in the last 5 years. In general, my recommendation is if you're screening for sexually transmitted infections, you should screen for syphilis as well. In terms of treatment, there's no major changes to the treatment guidelines. For incubation, primary, secondary, and early latent, it's intramuscular penicillin G once, with alternative regimen being doxycycline 100 milligrams twice daily for 14 days. I want to highlight the alternative regimens today, because as many people know, we do have some nationwide penicillin shortages going on, and it's important that we know these alternative options in case we don't have enough penicillin to go around. For individuals with latent of unknown duration, or tertiary, it's Pen G, 2.4 million units weekly for 3 weeks, or as an alternative, doxycycline 100 milligrams twice daily for 28 days. For neurosyphilis, ocular or otic syphilis, it's IV penicillin for 10 to 14 days. There is an IM option, however, it's daily for 10 to 14 days. And as a reminder, one of the things as we approach the penicillin shortage and think about who we can use doxycycline or the alternative regimens for, is a reminder that pregnant women do not have any alternative regimens, and we are seeing large increases in congenital syphilis cases. So pregnant women who have a history of penicillin should be desensitized and treated with penicillin. There is no acceptable alternative regimen. Going back to Jack's syphilis course, just as a reminder, it actually started with rectal pain. He then developed a rash, and then he went on to develop vision and hearing changes. And so he had multiple different stages of syphilis before his diagnosis was made. After being seen by the ophthalmologist, his RPR did return to 1 to 128. He was called by the Department of Health and came into STD clinic. We actually were able to arrange for a PIC to be placed outpatient, and he improved rapidly with 14 days of IV penicillin. However, while he went home, and for the first day or two, everything seemed like it was going well, 3 days later, he actually came back to clinic, saying, I think I might be allergic to the penicillin with these lesions on his skin. Hopefully, many people recognize those as the lesions of Mpox, and it's something we do need to start talking about again. Many people heard that there was an emergence of an Mpox cluster in Chicago recently, and while the numbers we're seeing are nowhere near what we saw last summer, it is still important that we're aware of this and think about this on our diagnosis still. I will also tell you that while we've had very few cases in New York City over the past few weeks, I was called for 3 cases just yesterday. And so it's very likely that in the summertime, with Pride events and other things going on, that we may see a small or large uptick in the number of cases. As a reminder, Mpox is a pox virus. It's an orthopox virus, so it's like smallpox, but not. There are many other orthopox viruses, and that there are 2 virus clades, and that so far this outbreak has been clade 2B that has a less than 1% case fatality rate. Classically, we think about Mpox presenting with a prodrome of fevers, chills, headache, malaise, myalgias, and lymphadenopathy, as well as a rash that's firm, deep-seated, well-circumscribed, sometimes umbilicated. It starts on the face and spreads to the extremities, including the palms and soles, progresses through several synchronized stages, is often painful, and can last for up to 4 weeks. However, during this outbreak, we've actually seen that the prodrome may or may not be present. It's only present in about half of patients. Additionally, we're now seeing more and more of the rash starting in the genital and perianal areas that may not involve the face or extremities at all. Instead of progressing through several synchronized stages, lesions can be in different stages simultaneously. And the presenting symptom may actually be proctitis, where you're unable to visualize any lesions. One other thing I want to highlight as we enter this summer season, we've done a great job trying to vaccinate patients who might be vulnerable to Mpox, and we don't know how vaccination will impact the appearance of Mpox. And so we really do need to have a very high index of suspicion, because it's both possible and maybe likely that people who are vaccinated may still be vulnerable, but their infection may appear different than those who were unvaccinated last summer. As a reminder, Mpox presents both with co-infections as well as similarly to many STIs. In terms of genital ulcer disease, things like HSV, syphilis, chancroid, and LGV. In terms of diffuse rash, things like syphilis, varicella, disseminated herpes, and molluscum. And then in terms of proctitis, things like gonorrhea, chlamydia, and HSV. I will tell you that I've now seen 250 patients with mpox, and even I am not convinced that I can make the diagnosis between HSV and mpox when the lesions look vesicular, or syphilis and mpox when it looks like an ulcerated lesion. And so my recommendation is to keep mpox on your differential. When you see lesions that look like these things, send testing for both, because visually there's no way to tell the difference. I try to predict it, and I've been fooled many, many times at this point. And so I always make sure we send the whole differential when we're looking at patients. These are just some examples of many of the mpox lesions we've seen. So an ulceration in the mouth, skin lesions. This is more of the classic umbilicated lesion. This is one that I might have thought was HSV if I didn't know better. The one scabbing over, and then one healing over here. And so mpox can look like a lot of different things. Testing is still through a vigorous swab of the lesions. We're not using serology for testing. And don't forget about doing comprehensive STI testing, because co-infection is common. Treatment is primarily with supportive care. We do have antivirals available for patients who have severe infection. In terms of prevention, vaccination is the key, and we have one slide to talk about that right here. So as a reminder, ACAM 2000 is a live vaccinia virus. It has not been used during this outbreak, but it is available. It requires a single injection, and you get a lesion at the inoculation site. Jynneos is a non-replicating virus. It's 2 injections 4 weeks apart, and maximum immunity is about 14 days after the second dose. I apologize, this booster should be every 10 years, not every 2 years. And it's FDA approved for age greater than 18. However, there's an EUA allowing it for individuals under age 18. The vaccination can be used both for post-exposure prophylaxis, can be given within 4 days to prevent disease, and 4 to 14 days to reduce symptoms, as well as for pre-exposure prophylaxis in epidemiological risk groups. So the current ACIP recommendations from February is that they recommend the 2-dose vaccine series for persons aged 18 years and older at risk of mpox during an mpox outbreak, which it still is considered now. Just so everyone's aware, we are starting to see some reinfection and post-vaccination infections. These are not large numbers. These are a relatively small number of infections. It's important to remember that people who've been vaccinated or have been previously infected can acquire it again. And so you shouldn't take it off your differential solely because of these factors. Just to wrap up today, what else can we do for Jack and Jill? And the answer is more prevention services. There's an old saying that an ounce of prevention is worth a pound of cure. And the 2021 STI treatment guidelines actually talk a lot about prevention, including HIV testing and retesting after treatment that we talked a little bit about today. Primary prevention methods like PEP and PrEP. I'm not going to talk about PEP and PrEP because that's a whole talk in itself. But I do want to remind everyone that the 2021 PrEP guidelines actually recommend that we should be informing all sexually active adults and adolescents about PrEP so that they know about it and can use it for themselves when needed. What I will mention quickly is partner services and expedited partner therapy. So as I said, when I mentioned retesting, reinfection is the most common cause for recurrent infections. And so to reduce that risk for patients with gonorrhea or chlamydia, the CDC recommends treatment of sex partners. Ideally, that would include bringing partners into clinic where you can offer comprehensive STI testing and counseling. However, that also includes expedited partner therapy or treating sex partners without seeing the partner, which is allowed. What's exciting is that EPT is now permissible or allowable in all 50 states and not prohibited in any, which is very different than when I started giving this talk, and I used to be a lot more red on this chart. It's also allowed in Michigan, and Michigan has a really fantastic guide on expedited partner therapy for gonorrhea, chlamydia, and trichomoniasis. In terms of updates to the guidelines, the biggest update was previously it was only recommended for heterosexual couples. But in the guideline update, they do now recommend expedited partner therapy for men who have sex with men using shared clinical decision-making. In terms of providing EPT, again, we should evaluate all sex partners in person if we can, empirically treat partners in the last 60 days, or the most recent partner if the last contact was greater than 60 days. And expedited partner therapy, again, is for heterosexual men and women, as well as men who have sex with men through shared decision-making. In terms of choice of therapy, it's pretty similar to our regular treatment. In terms of chlamydia, one big difference is that there isn't a lot of data on doxycycline for EPT. Most of the studies were performed with azithromycin, And so the preferred regimen for expedited partner therapy is either doxycycline or azithromycin. I will tell you, since I'm not seeing the patient, I tend to use doxycycline for people born male, particularly men who have sex with men due to the risk of rectal infection. However, because I'm not evaluating the patient for women and I can't assess their pregnancy status, I frequently will use azithromycin. For gonorrhea, here's where cefixime really comes in handy. You can use cefixime for gonorrhea EPT, and for trichomoniasis, it's metronidazole or tinidazole. Just to wrap up for today, we covered a lot of ground today, so please feel free to ask any questions. A reminder that extragenital gonorrhea and chlamydia testing was emphasized. Think about Mycoplasma genitalium for persistent urethritis or cervicitis. Have a high suspicion for Mpox in patients with a rash, ulcers, or other symptoms. In terms of treatment, we changed our dosing of ceftriaxone for gonorrhea to 500 milligrams, or 1 gram if people weigh over a kilogram, or over 150 kilograms. For chlamydia, doxycycline 100 milligrams twice daily for 7 days is now the preferred regimen. For trichomoniasis, metronidazole for 7 days, twice daily for 7 days in women is the preferred regimen. For Mycoplasma genitalium, resistance-directed sequential therapy with doxy followed by moxy if resistance testing is not available. For prevention, more liberal expedited partner therapy is supported, and vaccinate those who are exposed to Mpox, who might be exposed to Mpox. As a reminder, we're from the New York City STD Prevention Training Center, and we do have this clinical consultation warm line. If you ever have a complicated STI case you want to talk about, you can put it through the ccn.org, and somebody from our Prevention Training Center will get back to you. And with that, thank you all for joining today, and we'll stop for any questions.
Thank you so much, Dr. Zucker, for that presentation. That was fantastic, very comprehensive. As a reminder to folks on the line, if you have any questions, please drop them in the Q&A box. One question we have right now regarding more frequent STI testing throughout the year. How are you getting medical insurance to cover STI testing more frequently? This person is saying that we're testing and insurances are declining to pay for more testing within the year.
Yeah, so I think it's a question of both documentation and being willing to go back and push back against that. So we always document, probably over document our individual patient's risk, which I sort of in some ways hate having to put in the chart, how many partners they've had, how much condomless sex they've had, things like that, to really explain why they need to be tested more frequently. I sort of sometimes hate having to put those in the chart, but we have had success sending those to insurance companies to get them to reverse denials. So I think like a lot of things in medicine, it's a lot about documentation. And it goes back to why taking a good sexual history is important, because it really supports you needing to do more frequent STI testing.
Thank you. Another question here related to extragenital testing. Are there regulations for self-swabbing for male and female patients?
So this is a tough question because it's very much regulated both statewide. You know, the major platforms are validated for clinician collected samples. Many labs have self-validated patient collected samples, in large part because we now have like 1,000 articles that demonstrate that patient collected samples are equivalent, if not better, to provider collected samples and preferred by patients. However, since it's not part of the FDA package insert, you do need to make sure that your lab has validated self-collection before you send it.
Thank you. A question here about Mpox. Are we still giving Mpox vaccinations intradermally with a lower dose?
Not currently. So I think we've gone back to subcutaneous as our demand has caught up with supply. We've gone back to subcutaneous injections. Great.
So I just want to highlight a comment from Malaysia, from Michigan Department of Health in the chat, that the SOM lab has not validated self-collection for extragenital testing. There is a question, Malaysia, just asking if there is rationale for that. I don't know if you wanted to share any more related to that from Michigan Department of Health point of view.
Yes, so the validation process was started, and then COVID happened. And then that slowed things down. And so it never really got back on track just because of the, I believe, if I'm not mistaken, just the traffic inside of the clinics, and the clinic that we were doing the validation with had some issues with that whole process. But I am in constant contact with our lab, and they are giving me updates as things progress and if things change. But as of right now, self-collection is not validated with our lab. Now, if you do use a separate lab, check with them, but as of right now, not with us. And I'll give updates if things change in the future.
And I hate to say, but that's very common because, again, because the companies have not validated, each individual lab needs to validate it on their own. And it is a time-consuming and difficult process. And many people got held up by COVID and other things.
Thanks for that. So is that, Malaysia, does that also true for self-collected vaginal swabs? Is it any self-collection? Someone's asking about that.
So I can actually, I think, answer that question because self-collected vaginal swab is the one exception that is FDA approved, actually. So self-collected vaginal swab is on the package insert, so it should not require additional validation. So you can correct me if I'm wrong, but that should be fine in Michigan because it is on there. But self-collected pharyngeal and rectal swabs are not on the package insert.
Thank you. And yes,
yes.
Yes. Any other questions from folks? I know we covered a lot today. I'm sure you're still digesting, but if there's any other questions, please feel free to drop them here in the Q&A tab. We have a couple minutes left. Okay, if there are no additional questions, we can go ahead and wrap up. I just want to thank everybody again for spending this hour with us. We really appreciate your time and hope you found this presentation helpful. Thank you for the thank you to the Michigan Department of Health for partnering with us on this webinar. We really appreciate it. And thank you again, Dr. Zucker, for an excellent presentation. As a reminder to everyone, I will be sending out CME instructions later today, along with a copy of the slides. And this recording will be available on our website, likely within a week or so, and I will send an additional email once it is available online. I hope everybody has a great rest of their day.